Thanks, Adriana. Thank you very much to the organizing committee, in particular Mort and Ruben, for inviting me. And thank you, Dr. Palumbo, for basically making all of my arguments. So I could just cut this short and say, how many people tomorrow will see a patient in clinic, transplant ineligible, and will give them melphalan? I rest my case. Well, I won't quite rest the case there, but let's talk a little bit more about alkylating agents and transplant ineligible patients. Thank you, Antonio. Actually, that was a great talk and highlighted some very good points. Obviously, the idea of a debate like this is not simply to say yes or no, but to understand the granularity. So what do I want to achieve in the next few minutes? Review the emerging data regarding replacing melphalan and prednisone as the so-called backbone and upfront therapy. I would suggest strongly that very few patients require melphalan and prednisone in their initial therapy. Provide some practical advice as to how we initiate therapy in older patients. Unequivocally defeat, notice that he's my friend, Antonio. We are good friends. We've had some very good times together, so I want him to still be my friend after this. I'd like to make it to Italy in 2015, so I do want to make sure that we retain our friendship, which we will. And perhaps slightly concede, depending how you define the word alkylator, whether or not you're going to include cyclophosphamide in that. For the purposes of the study, generally speaking, I would not think of it as the same kind of alkylator as melphalan, and I'll explain as we go. So really, as I said at the luncheon discussion, if you want to nap for the next 15 minutes, just listen to this slide. Here are the 4 key points I'd like to make. Number 1, novel agents are equivalent, if not superior, to melphalan plus a novel agent in elderly patients not eligible for transplant. Number 2, it is clear, as we've just heard in the last few minutes, that melphalan, prednisone plus something clearly results in greater short-term, not to mention long-term, toxicity. Number 3, as survival is extended in myeloma, using melphalan up front is not desirable due to marrow toxicity. I think this is a point that we sometimes don't fully appreciate. As we've heard repeatedly today, and we'll hear more, people are living longer with myeloma, and that's fantastic. Not only in the younger patients who are undergoing transplant, but in elderly patients as well. And so we need to have a long-term approach to these patients. And if I sit down with a patient who's not transplant eligible and I want to look at their long-term survival, using melphalan initially is not perhaps, as I suggest, an appropriate decision because it may compromise their marrow function in the long term. And then number 4, as we've heard already today, and I'll highlight it a little bit more, melphalan can possibly, not always, but can possibly, we don't want to overstate this case, hence number 4 in the list, but it can lead to increased second primary malignancies. So we still think of myeloma, generally speaking, as a disease with rather significant differences and variability between high-risk and standard-risk patients. This applies to both transplant-eligible and ineligible patients. We published recently our consensus guidelines at Mayo and the MSMART guidelines, distinguishing these 3 groups of high, intermediate, and standard risk patients. As you see from this slide, their general expected survival as of the last decade, but moving ahead, we know these numbers, thankfully, will continue to improve. And so in our transplant-ineligible population, we've moved to now essentially removing melphalan prednisone as standard therapy up front in essentially all patients, with perhaps the exception of melphalan prednisone and bortezomib in the intermediate risk patients. Although, frankly, for the majority of those patients, we do recommend Cybor-D. And I'll comment shortly that I think Cybor-D really is a mild alteration to MPV or VMP, depending on how you prefer to pronounce it. And we now recommend lenalidomide dexamethasone in standard risk patients for initial therapy when not on clinical trial. So argument number 1, novel agents are equivalent, if not superior, to melphalan and prednisone. Plus, there are many ways that we could look at this, but I would take this data as a comparison of MPT, VMP, MPR, MPRR, and now VTP. So even if we look at this, this is the final column that now does not include melphalan in its portfolio, that we see similar, if not improved, CR, VGPR, and overall response rates with equivalent progression-free survival in these individuals. So this was an important initial study. I know we have more mature data from the MPT study, as was demonstrated, but here we have data that is clearly pointing in the direction that we can get to that same end without requiring melphalan up front. Most of you are quite familiar with the lenalidomide plus high-dose dexamethasone versus lenalidomide, and now what would be considered standard-dose dexamethasone study. Most of people think of this study as patients who are going on to transplant, but let me remind you that this was a study that included a number of patients who were older patients who were not genuinely eligible for transplant, and those groups of patients had an excellent response to the combination, similar to younger populations. That, as we know, due to this, that leading to us using standard dose dexamethasone or lower dose dexamethasone more commonly, had an improved survival at 1 year with reduced grade 3 or worse adverse events. If we look a little bit more specifically at those patients who are over the age of 65, over the age of 70, and even over the age of 75, we saw that this response was retained. So we have a very large ECOG study that we tend to think of as teaching us absolutely that low-dose dexamethasone is safer than high-dose dexamethasone, but it also concomitantly teaches us that the strategy of using lenalidomide and dexamethasone is both feasible and effective in older patients. As you can see from this slide, in terms of their 12 and 24-month survival, we see very good even in the older population. Similarly, other studies have looked at now taking melphalan out of the standard arm, as in this case here, as we see with CRP and RD being evaluated, where initially, as we saw already from Dr. Palumbo's slides, that there was no significant difference. Similarly, again, being able to use bortezomib and prednisone as opposed to including it with melphalan and prednisone, or also using it with cyclophosphamide, is another legitimate strategy that similarly has demonstrated at least equivalency, if not superiority, to the melphalan prednisone arm. So I would conclude in my point number 1 that melphalan and prednisone is not necessary, at least initially, that lenalidomide dexamethasone and bortezomib dexamethasone options are very effective for the patient that you'll see in clinic tomorrow, or I shouldn't say tomorrow, next Monday, because you'll all be here tomorrow when you're caring for your patients. Argument number 2, melphalan and prednisone plus results in greater short-term toxicity. I don't think I have to emphasize this point too harshly. Who's the author on this paper? Palumbo. Oh, yes. So this is from Dr. Palumbo, who demonstrated that in the 3 drug combinations, using melphalan, prednisone, and lenalidomide led to increased discontinuation in that older population who are not eligible for transplant, and as a result had significant reduced dose intensity. For which he's very well known for the study comparing MP, MPR, and MPRR. And we learned initially that there was really no difference between the MP and the MPR arm. What led to benefit in these patients was the extended use of lenalidomide. So it was really not the starting gate of MP that helped, it was the continuing gate, if you will, of lenalidomide that led to the superior outcome. And this led to his treatment algorithm that he has suggested already between the go-go patient, the moderate go, and the slow-go patient, as he's already demonstrated to us. So I would conclude then that 3 drug regimens that include melphalan are clearly more toxic and not necessarily more effective, as we demonstrated in argument number 1. And dose reduction, as we know, as a practical point, is very important. We discussed this at lunchtime, be it with thalidomide or other agents, that we really have to think of these agents somewhat differently in the older population, especially in the very elderly population over 80. Argument number 3, as survival is extended in myeloma, using melphalan up front is not desirable. We know that we want to be careful. There's always a balanced argument. I don't want to use everything possible for my patient first line and not have options later, but at the same time, I don't want to undertreat my patient currently. When we think of lenalidomide, when we think of melphalan, it is an agent that we know can cause both short-term and long-term marrow toxicity. As I've suggested, it is not one of the initial cards that I would want to play when I now think of my older patient. Even if I have a patient come into clinic tomorrow, aged 75, I'm not anticipating that they're only going to live 2 more years. In fact, I'm expecting them to live many more than that. And we've been demonstrating, this is just some of our Mayo Clinic data demonstrating that between 1970, the early 70s and the mid-2000s, we saw a significant improvement in overall survival of patients of all ages. And even within the decade of the 2000s, we have seen a dramatic improvement, whereas now we can see that our progression-free survival and overall survival of patients has dramatically improved. And a lot of this, of course, is not simply due to the use of autologous stem cell transplant, but indeed because of the novel agents that we have and many of the ones that have been discussed at this conference that we hope to have more available to us in the future. So argument number 4, and my final argument, would be melphalan can lead to increased second primary malignancies. This is always an issue that I want to present with balance. And in fact, I commend my colleague, Dr. Palumbo, on how he presents this, that there's a balance between a risk of a theoretical phenomenon and the treatment of an actual malignancy that you have in front of you. So we want to balance our oldest and the most important adage in medicine: above all, do no harm. I don't want to induce greater harm in my patient. At the same time, I don't want to hold back treating an active malignancy in front of me for the potential risk of a malignancy that may come down the line. So we have to approach these with balance. However, the numbers have been quite convincing that when combining lenalidomide with melphalan, that induces the higher risk both of hematological and second primary malignancies. There are risks inherent. I tend to think that there is a risk simply in myeloma of a secondary malignancy, independent of any intervention, and we have been able to see this before. We have seen increased risk of malignancies with almost every agent that has ever been used in multiple myeloma, so the baseline risk is not zero. But we don't want to enhance that risk in a strategy when perhaps we can save, as I've mentioned, the melphalan for later and not use it up front. So as Dr. Palumbo already noted in one of his slides, the highest risk for hematological malignancies in particular was the combination of lenalidomide and melphalan together, and in particular oral melphalan. Again, we think of the second primary risk post-transplant in the recently published maintenance lenalidomide studies, but here we see that perhaps even a greater risk in those who are on oral melphalan, which is somewhat a surrogate marker for age, of course, so we have to appreciate that the older population are always going to be at greater risk of secondary malignancy. And so even more so should we be cautious in using oral melphalan in these patients. Sorry, skip ahead here. I think our slides are frozen for a moment. Maybe you could move it ahead for me, please. So the concession that I had made previous to this was that cyclophosphamide is not exactly melphalan, as we know that. And we have been extensively using cyclophosphamide as an oral agent once weekly, with the combined benefit of being able to boost the effect of almost any regimen it's added to without necessarily increasing the risk of secondary malignancy and the cytopenias or the nausea that might be associated with other alkylating agents. So the so-called new Cyborg-D, just pragmatically, this is something that I get asked perhaps more so than any other question, is how do you deliver these agents? We prefer to use all three on a weekly basis, considering a cycle as 4 weeks without break. We prefer to use cyclophosphamide orally, in fact, over intravenously for a number of reasons. Dr. Merlini referred to one of the papers we had recently published using Cyborg-D in amyloidosis, and in that I write a paragraph describing why we favor oral versus IV cyclophosphamide. We slightly increased the dose of bortezomib to 1.5. Our preference milligrams per meter squared. Our preference is to give it subcutaneously, but in some situations may use it IV, and standard dose dexamethasone. As I mentioned, we don't have an off week. We give it continuously every 4 weeks. We found this to have less neuropathy, more convenience, and equal efficacy. And please don't forget to give viral prophylaxis. We still sadly see patients coming in with shingles and others that could have been prevented. And as I mentioned from the start, really it is a modification to some degree, and we described this in the MSMART guidelines, of VMP in altering taking away the melphalan and replacing it with cyclophosphamide. So in summary, the very four arguments that I've made from the start, I do think that novel agents are equivalent, if not superior, to MP. MP plus results in greater short-term toxicity. As we think long-term strategy with our patients, we don't want to expose them to marrow toxicity early on, and melphalan can indeed lead to increased second primary malignancies. My final and last slide, a little bit tongue-in-cheek. For those of you who are at ASCO this year, Dr. Palumbo, not knowing that we were going to have this debate, made the comment, the Americans were right, we should not use melphalan up front in elderly patients. And for those of you of Italian background, I hope this translation is good. I tried with Google Translate, but then checked it with an Italian friend that I thought might clinch a little bit of our debate today, that from his own mouth, Dr. Palumbo is not recommending upfront melphalan. And with that, I'll thank you for your attention.